So moving on to the introduction of our wonderful speakers tonight, it's such an honor to have them both here. Christine C.O. Ritchie is the Kenneth Meinecker Endowed Chair in Geriatric Medicine at MGH and Harvard Medical School. She is the director of the Center for Aging and Serious Illness in the MGH Mongan Institute and the research director within the MGH Division of Palliative Care and Geriatric Medicine. She also serves as director of the MGH Dementia Care Collaborative and associate faculty at Aradnid Labs. Our other speaker, Matt Russell, is the clinical director of geriatric medicine and medical director of the ambulatory geriatric medicine initiatives. Dr. Russell is board certified in internal medicine, geriatric medicine, and hospice and palliative medicine, and has practiced across the spectrum of healthcare delivery in both fields, including home and office-based practices and skilled nursing facility, as well as acute hospital care. So you can hear all of the experience that's behind our speakers tonight. So I will turn it over to them. Christine and Dr. Russell, please take it away.
Excellent. Thank you so much, Susan. So we're just going to take a little spin through how we talk about diagnosis, especially in the outpatient setting. So I'd like to start with some basic clinical vignettes of people I've had the pleasure of encountering in their healthcare journey. The first person I want to talk about is Sandy. So she is a 74-year-old retired school administrator. She's been noticing that she's more forgetful of late. She lives alone since her husband passed away just a few years ago. She's still driving, but has stopped going onto the highway and really doesn't like to drive at night. She tries to avoid unknown driving routes. At church, she's having a hard time remembering the names of some of the other churchgoers and feels self-conscious about it. Her daughters have noticed that she is not cooking like she used to. She used to be a fantastic cook and entertained all the family holidays. Sandy tells me that she can't be bothered to cook a big meal for one, and microwave and takeout is just a lot easier. She goes on to say that one time she left the gas stove burner on, and that made her concerned that she was developing memory problems. And now let's meet Dave. So Dave is a 76-year-old retired bus driver, and we are seeing him for an annual checkup. Excuse me. He lives at home with his wife, Nancy, and their 2 dogs. Dave feels that he's doing physically well and tells me that he's exercising several times a week and keeping himself busy with his hobbies, including a record collection and bowling. Nancy rolls her eyes as she makes eye contact with me. She takes me aside while he's getting routine blood work and tells me that Dave has not been a part of his bowling team for over a year. He hasn't really left the house for several months since their kids took his car keys away. Dave had had several episodes of getting lost, and the last straw was having the state police call her when he was found at the state border. He is more forgetful and gets angry at her when he misplaces things in another room. So these are actually not at all uncommon clinical stories that we might encounter in the ambulatory setting. And what we're hoping to talk to today are what are the signs, the things that are concerning for us as we wonder if someone is developing dementia. How do we make the diagnosis of dementia? And then what? What are the ways that we can plan for someone to have a safe and positive experience through this? So let's start with some common signs of dementia that should trigger a warning. When people are having memory loss, and it's more noticed not by us, but by people around us, that tends to be a bit of a red flag. We may have trouble communicating or finding words. Not necessarily this is the word on the tip of my tongue that I can't get out, but sort of common words that one would expect that I'd know. I might lose the ability to do my usual tasks. If I was someone who liked to do crossword puzzles and you'd see me struggling with that, that could be a sign of it. If I'm having trouble reasoning or problem solving around things, that can be another sign. Being overwhelmed by complex tasks. And when I say complex, I don't mean impossible tasks, I mean multi-step tasks. and then if you're having difficulty with planning and organizing. Now do the next slide. I think this is Christine.
So how is dementia diagnosed? Many of you probably are well aware of this or have had some personal experience yourself, but just to sort of go through it. Dementia is diagnosed first and foremost by a conversation with your doctor or your clinician about what might be risk factors for the development of dementia. And just as a reminder, what are some of those risk factors? Things like a sedentary lifestyle, things like maybe having a history of not a very healthy diet, having a family history of somebody living with dementia, having a history of cardiovascular disease, high cholesterol, diabetes, depression, difficulty with a longstanding history of difficulty with sleep, and also sometimes a history of head trauma. So those are all risk factors that if you were to come in and talk to your clinician about your concerns about thinking, those might be questions that you would be asked. There are also a number of tests that we then conduct to try to get a sense about what parts of people's brains are working in a way that's more consistent with their age and their educational status, and what parts of their brains are just not working quite at the level that they might have in the past. Sometimes this can be a little bit tricky because depending on someone's background, say they never had the opportunity to get a lot of education in their background, they may not do as well on some of these tests, and it might not mean that they're actually having troubles with their thinking. And then conversely, some folks who may have PhDs in astrophysics or something like that may have the ability to compensate for some of their difficulties around their thinking, and a traditional cognitive test may or may not be sufficient. And in those instances, oftentimes people are recommended to receive more formal testing, what often is called neuropsychological testing. And neuropsychological testing provides a much more comprehensive battery of a lot of different tests that test different parts of the brain's functioning. So our brain is an amazing organ, has a lot of different things that it does. And what neuropsychological testing does is it engages in trying to understand all those different parts. In addition to that, then there's often blood work that's done. And usually the blood work is not so much to diagnose dementia, but to look for other things that might be behaving like dementia. And that might be something like someone's thyroid function not working well. Maybe they're having a vitamin deficiency like vitamin B12 deficiency. And we check that blood work just to make sure that that's not contributing to the person's difficulty with thinking. And then more often than not, we will engage in some kind of brain imaging, things like either a CAT scan or a MRI. And that's even more important if someone has had a history of some kind of trauma to their brain, especially recently. Now, depending, often by and large, if someone has more traditional features of some of the more common causes of dementia, your doctor, your clinician may be able to make the diagnosis on their own. Sometimes, however, the sort of array of symptoms or features of the presentation are more confounding. And in those instances, then a referral often can be made to a specialist, either someone in geriatrics, neurology, neuropsychology, or geriatric psychiatry for more intensive evaluation. And we generally do recommend for people who have a very abrupt and accelerated decline in terms of their thinking, or if they're developing changes in their thinking very early on in their ages, like in their 30s and 40s and 50s, that we make a referral to neurology for specialized testing. There are other tests that you've likely heard of, and there are many of these tests are investigational with one exception, and that is the Amyloid Pet Scan The amyloid PET scan is the one scan of its type that's focused on the evaluation for Alzheimer's disease that's approved by Medicare for reimbursement. And these PET scans, but it's not the only kind of PET scan. It's one of many different types. These PET scans often use a radioactive drug. And in this case, it's a radioactive drug that's attached to amyloid plaques. Amyloid plaques are two of the features that we often see in Alzheimer's disease, amyloid plaques and neurofibrillary tangles. And many times what we will see is features that are consistent with the distribution of those amyloid plaques in an amyloid PET scan in somebody who has Alzheimer's disease in particular. Generally speaking, amyloid PET scans are not necessary for routine evaluation or diagnosis. They're usually saved for someone who's presenting in a sort of atypical way where we need just a little bit more guidance about what might be going on. None of these scans establish the diagnosis, but they just add some additional facts or more sort of features to guiding to a final diagnosis. Some other types of scans that you might have heard of is an Fdg Pet Scan or a fluorine fluorodeoxyglucose scan. It's also been used to assess for Alzheimer's disease, and a SPECT iodine 123 scan. Other scans that are used as part of research protocols include the high spatial resolution MRI scan. So many more and more tests are being developed for us to better understand dementia, even some blood tests. And we're looking forward to those being sensitive and specific enough that they can actually be routinized into practice. We're not there yet. Now, one thing I just want to highlight is that when you hear the word dementia, many people think of it as one thing, but dementia is sort of like the word cancer. It actually means a number of different conditions that sort of fall all within that sort of spectrum of types of conditions. So dementia involves any kind of chronic neurodegenerative changes to our brain, but there are many different kinds of dementia and they behave differently. And so understanding what kind of dementia somebody has can be helpful to the person living with the dementia and to their care partner, because it might help them anticipate a little bit of what the future might look like. So here you can see on the left, there's a little pie chart there, and Alzheimer's disease is by and large the most common cause of dementia, but there are other causes like vascular dementia or mixed dementia, which generally means someone who has a little bit of vascular dementia and Alzheimer's disease combined, dementia with Lewy body, Parkinson's plus type dementia, and frontotemporal dementia. And under frontotemporal dementia, there are actually several different kinds of frontotemporal dementia, including both the behavioral variant and the non-behavioral variant, including primary progressive aphasia. Now, what do all those colorful charts mean on the right side? The point of those colorful charts is to highlight that these different kinds of dementias actually do kind of behave differently in terms of the way they work on the brain. And so you can see here that if you look at these different colors, they represent different types of dementia. That MMSE stands for the mini mental state exam. It's one of those cognitive tests we were talking about. Different kinds of dementia behave differently over time with that cognitive test. And likewise, different kinds of dementia influence our ability to speak, our ability to communicate with language differently, our attention, our ability to understand our environment, which is what we mean by visual spatial functioning, whether or not we get lost easily or have trouble recognizing where we are. Executive functioning are those things that are learned behaviors like writing in balancing our checkbook, tying our shoes, using complex instruments like the remote control TV monitor, for example. Those are all things that influence executive functioning. And the point here is that with these different kinds of dementia, they all have different influences on how that change occurs in our brain over time. just want to highlight that, and some of you may have experienced this, that obtaining a diagnosis of dementia can take time because it's a combination of understanding what's going on both with one's other comorbid conditions, like how much they're influencing what's going on in our brain, and then also what's happening to us over time. And so as you saw from that picture, sometimes just being with somebody over time can help us understand what kind of dementia they're experiencing. For example, if someone is experiencing visual hallucinations, that is, they're seeing somebody who other people can't see in the room, and they're seeing that early on in their lived experience with dementia, that's more what we see in somebody with Lewy body dementia, where in someone with Alzheimer's dementia, they can experience hallucinations, but it tends to be much later in the course of their illness. So the takeaway here is that obtaining a diagnosis can take time and, truth be told, some perseverance. So we would encourage you that if you're on a journey with a loved one, or if on trying to discover for yourself what's going on with your own cognition, is to be persevering and keep asking questions, keep trying to figure out what's going on. And in time, you will be able to have a sense of what's going on in terms of a diagnosis. Now, receiving a diagnosis of dementia can be very frightening. And many people sort of have what I call a don't ask, don't tell attitude towards getting a diagnosis of dementia, which is if I don't ask, nobody will tell me, and then I just won't have to deal with it. And that's certainly an understandable response to something that is as frightening as the diagnosis of dementia can be. But dementia is something that does require planning. And because it is something that changes over time, your best way of staying in control and making sure that your voice is heard is to have the information that you need so that you can plan ahead. So when Dr. Russell and I were talking about sort of why bother with actually getting a diagnosis of dementia, there were two sort of themes that bubbled up for us based on what people who live with dementia and their care partners have told us, and based on our own personal experience. I've personally cared for somebody living with dementia, and this has certainly been my experience as well. So first is the diagnosis serves as power because it helps you know what the future is going to look like. It also helps you articulate what's important to you and enables you to think about what you want to accomplish or get or do while you are able. Making sure that you're articulating what's important to you, making sure that you're doing those things that are important to you while you're able is frankly a good practice for all of us, because all of us likely in our future will come to a time when we're not as able as we are right now. What's important to me that I want to make sure others know about so that they can speak on my behalf. So making sure that other people who care about us actually know what's important to us. You know, some of us may not be into having those kind of conversations just on a regular basis. And so the diagnosis can serve as that opportunity and impetus to say, how do I make sure that those people in my life are important to me? They know what's important to me and that they can speak on my behalf. And then last, what legacy do I want to leave? Are there things I want to do now? People I want to communicate with now? Letters I want to write now that I want to do now while I am able? There's power in that diagnosis. And in that frame, it can be actually really useful to proceed with trying to understand what's going on. Knowledge is also love. And what do I mean by that? Well, generally speaking, when our care partners know what's going on, just really having trouble there. When they know what's going on and they actually understand what's going on with our condition, if we're the one living with dementia, they actually can navigate the future better. They can also link up with supportive networks that can support them while they support us. Informed care partners are less likely to become isolated. They will recognize that it's important for them to diversify their support portfolio. In fact, I would encourage all of us to diversify our support portfolio because it's very easy to become isolated. And then informed care communities, especially if we're talking about a family or an extended family, will be able to make better plans and they'll understand the trajectory of the disease. And so that knowledge enables us to do a better job of providing care. Here's an example of that from this book called Learning to Speak Alzheimer's. This book serves as just an incredibly useful guide to any of us who are caring for someone with dementia, not just Alzheimer's disease, I would say, but any kind of dementia, to understand sort of what might be going on, how we might deal with those things in a way that's loving, supportive, productive, how we can address and adjust ourselves to some of the loss that we might be feeling and experiencing. So if you haven't read this book, this is a wonderful book to read. And it serves as just a great tool for thinking about how to sort of navigate what the future might hold. There are also a series called the Roadmap series that were developed here at Mass General by the Massachusetts Alzheimer's Disease Research Center, and the web link is there below. And the Roadmap series actually offers a lot of guidance to all sorts of things, both getting the diagnosis like we're talking about today, caregiving, navigating the acute care setting, which can be profoundly daunting if one is living with dementia, what the pros and cons are of research participation. And then if you're in that space where you might be worried that you are at high risk for the development of dementia, what you might be able to do to prevent it.
So this just leads into the pearl number one that we like to talk about in the dementia journey. Before you take someone else's pulse, check your own. You've got time. You've got time to plan this, whether you're the person with dementia or caring for the person with dementia. And having that time and the ability to plan for all the things that Dr. Ritchie said is really key. And we'll go to the next slide, which will show us what I like to talk about, pearl number 2, the 6 Ds of affirmative aging. What that means is basically we're looking at the different domains of our existence in the framework of what might change over the course of this disease. So for example, domicile. What's the plan for my living at home? Is it one floor living? Will I have the ability to navigate stairs as this disease progresses? What is the access to community services? If I am, remote in a farmhouse far away from a senior center, that might be a challenge as my loved one is struggling with dementia. So a lot of times people will start thinking about retrofitting their home as people acquire functional disabilities, and also talk about things like fall risk prevention. The next issue is dollars. Finances are a reality for this phase of life, and many are on fixed incomes. So it is important that we understand how to protect our assets and how to make the most so that if we do need to be able to pay for care, we have the resources. So, for example, understanding what it would be to have care in the home versus care in a facility. How can I afford my medications is another part. When we start to see that people are having, multiple medications, asking your doctor to say, hey, look, is this, are any of these medicines that might be very costly, are these negotiable? Are these still quite necessary for where I'm at? You may be surprised at that answer. That sort of dovetails into drugs. There are many times that we are many shifts in a kitchen, as doctors and specialists, and patients who have dementia might find themselves on medicines that either will not benefit, their use will not benefit them in the time allotted, or they might actually cause some adverse effects that could exacerbate symptoms associated with dementia. So a thorough medication review from your primary care doctor or geriatrician is key. Both of our cases today mentioned driving. This is the most difficult conversation we have in geriatrics, I would say, and I think many family members would agree. Our freedom and independence as Americans is so wrapped up in our love for the automobile. It's not just a mode of transportation. It stands for so much more than that. And for patients who have cognitive impairment, they may not have the insight into the fact that they have problem driving or are at risk. I can't tell you how many times I've sat across from someone who scored very poorly on cognitive testing, who said, I would never get behind the wheel if I thought I wasn't safe enough. And unfortunately, the insight of that individual isn't always there, and it can be very heartbreaking to say to the patient, or have the family say to the patient, I don't think driving is for you anymore. There are resources around having a conversation with a loved one about driving, especially out of the Alzheimer's Foundation. So Alzheimer's.org, alz.org, the dementia driving, if you search under that, you should be able to find it. What I have found very helpful, if patients are able to use rideshare apps in the early stages of dementia, or even if they just don't want to brave Boston traffic, I encourage them to get up to speed on using things like Uber or Lyft. It can be challenging as cognitive impairment progresses, and so sometimes we ask family members to coordinate with their loved ones around the use of those. The next thing that we want to think about is decision making. Now, right now, I have the ability to decide both my financial and healthcare decisions. But as my dementia progresses, I may be at risk of making errors, and I might need some help and oversight. That's all fine. But what I also want to make sure is that whoever is going to be acting in my stead, who's ever going to be my proxy in these affairs, knows what my wishes are. So this is what Dr. Ritchie was talking about, really using this diagnosis as a springboard to say, here are the things that are important to me, the things that I would want for myself and the things that I wouldn't want for myself. And it isn't so much, we'll often hear about people talking about this in terms of, do I get resuscitated or do I get intubated? But that isn't really the way that this goes down in dementia. What more happens is, what happens to me if my care needs outstrip the ability of me to be cared for where I'm residing, like in my home? We've had so many times where family members have said, I promised so-and-so I would never put him in a nursing facility. And it's, you as the healthcare provider are talking to someone who's, got darker circles under their eyes. They're wasting away to nothing because they're neglecting their health. They can't physically do this anymore. And, to be able to have this conversation upstream and say, I will care for you. As your care provider, I will ensure you get the best care. And that sometimes does mean having you stay in a place that isn't your home so that I can know that the people are doing the heavy lifting and I just have to be the loving family member. And this dovetails into our decline and death. This is a progressive disease that will claim patients, and we know that this is happening. There are more yesterdays than there are tomorrows, but that doesn't mean that my experience has to be a medical conveyor belt. And this is something I always encourage families to start talking about, because when we know that the time is bounded, perhaps more than we would know for the general population, we have the ability to choose what that looks like. And if it's informed by love and knowledge, it can be much more comfortable rather than the back and forth to the hospital for one medical problem after another without a real improvement in health status. So I just encourage people to have that, that conversation while you still can. Just the next slide, I think. I think this is Dr. Ritchie.
So pearl number 3, don't do it alone. In the United States, somehow we think that we can do life on our own, but we do know that as a species, we do better when we're connected and when we're in community. And this may mean asking for assistance at times. Some of you may have heard of a book that's become fairly popular lately called A Boy, a Horse, a Fox, and a Mole. If you haven't had a chance to read it, it's very lovely. It's mainly pictures, but it's just incredibly heartwarming. And in the story, the boy says to the horse, "What is the bravest thing you've ever said?" "Help," said the horse. Asking for help isn't giving up, it's refusing to give up. And so thinking about asking for help is something that we do as a way of staying connected to others, is something that we do that's necessary for us as a species. It's something that we do because we also love those that we're caring for, is a different frame. And it's a frame that I would encourage you to consider adopting, even though it may feel at first hard and challenging. Now, there are a number of resources out there, and many of you are probably quite familiar with these resources. Dr. Russell already mentioned one, and that is the Alzheimer's Association. And the Alzheimer's Association has a number of different resources on their website. I highlighted in particular, if you look under help and support, you can find a lot of different things there that are available to you. You're here, so you probably know about the Dementia Care Collaborative, and we also have a lot on our website to try to support you, and a number of resources that we would love to avail to you. Another resource that I found to be incredibly valuable, if you haven't heard of it already, is the Family Caregiver Alliance. And even though it does not focus on dementia per se, it's really a terrific resource for family caregivers, and can sort of help normalize some of the things that you may be feeling, where you may be thinking to yourself, am I crazy? And then you'll realize that a lot of other family caregivers are going through the same thing, and it can also serve as a source of community. There are other sources of community in our, or other sources of support in our community. We have Boston Age Strong. We have our special access programs, our aging special access programs here in Boston. We have Boston and Massachusetts dementia friendly communities. So there are a lot of resources that are out there. You know, I would just start with a few. Most of us, by the time we start thinking about needing help and resources, we're pretty tired, we're pretty burned out, and you may need to actually call on somebody to help you with this. You may want to call on one of your friends and say, listen, I need help and I'm just too tired. Can you just go look up a few things for me? But we all need to support each other that way. Pearl number 4 is to get involved in research. So there's a little known, I think, fact that people who actually are involved in research have better health outcomes. And why is that? Well, I think it's a couple of things. We don't completely know why, but this has been shown in a number of different studies. And part of it probably has to do with the fact that when you're involved in research, you've got more people looking out for you. You have more people monitoring you. If something goes awry, there's yet another person you can call and say, I'm worried about this. And if you haven't had a chance to go to the MADRC website, this is the Massachusetts Alzheimer's Disease Research Center website. They list studies that you could potentially get involved in of all kinds. Studies if you don't have any problems with your thinking, but you're interested in dementia-related research, because there is a great need for healthy volunteers. Studies for if you're just beginning to experience something like mild cognitive impairment, or studies that are further down the path that are available if you are experiencing dementia itself. There's studies for caregivers, because I think there's increasing recognition that caregivers need better support, and we need to study how best to offer caregivers good support. So with that, I'll turn it over to Dr. Russell.
Great. So just in finishing up, so Sandy, just to remind you, is our 74-year-old retired school administrator. So she was evaluated, and in the course of that visit, she admitted that COVID has been very hard for her, and she's been feeling down. Additionally, some blood work was done, which showed that some of her vitamin levels were on the low side. Her cognitive testing, her screening test, revealed only very, very mild cognitive impairment, and she screened positive for depression. So these were the interventions we did for Sandy. We made sure that we repleted the vitamins that she was deficient in. We added an antidepressant. One of the things that's really important to understand, especially in times of COVID, is that depression and dementia do have some features in common around low motivation, not really engaging in usual activities or losing usual activities, troubles with concentration. So I think in this case, it was really more depression. But that doesn't mean that there might not be a problem ahead. And so in talking with the patient and her family, we created this, the daughters created this new idea of basically taking Sundays at mom's house to actually cook meals for the week. And they made a family event of it and prepped in her kitchen. And then they'd have a nice Sunday dinner, and mom's kitchen was stocked. So all she had to do was reheat. The primary care doctor is planning to repeat cognitive testing in 6 months to see, okay, was the difference just nutrition and a treatment with an antidepressant and kickstarting her into some activities in her community and whatnot, which was the other intervention, or was this the start of something? And this is, again, to Dr. Ritchie's point, the diagnosis sometimes just takes time. And you don't want to just label someone with something without doing the due diligence to make sure that the reversibles and treatables out there haven't been assessed for. And now the next slide. Now, Dave was a different story. So his physical exam and blood work were fabulous. When we asked him how he felt his memory was doing, he said, it's fantastic. I don't have any problem. But we did some objective cognitive testing on him, and he struggled with many of the domains that Dr. Ritchie talked about, whether it was visual spatial, his ability to recall, word finding, thought abstraction, and even just basic orientation. So he actually scored in the moderate dementia range on screening test. We did some brain imaging, and it showed that his brain volume, the amount of brain mass there, has indeed shrunk, and it has shrunk preferentially in certain parts of his brain in a way that's a hallmark for Alzheimer's disease. So now what did we do with this? Well, we shared our diagnosis with the family. And we also shared Learning to Speak Alzheimer's book with them, because what I was witnessing in the visit was, remember, you don't do that anymore. Remember this. There was a lot of trying to correct what the patient clearly had forgotten. So since Dave continued to say he doesn't have any memory problems, and he has clearly no insight into his deficits, we decided not to keep sharing that information with him, because it would be like a revisit of that every time. Fortunately, he and his wife had already completed a healthcare proxy form and power of attorney paperwork. Those are very important to complete early in the process, because we want to make sure that, number one, that's all set up, but that the right person has been chosen, even though he and his spouse are healthcare proxies to one another, you can imagine that if his wife gets sick and he's listed as the healthcare proxy, that's a problem. So it has to be both updated and make sure that it's someone who actually will represent your wishes and values, even in the face of them making a decision that would result in you passing away. This is oftentimes something that people struggle with in dementia care. The patient might have been very clear, I don't ever want to have a feeding tube, don't ever do this to me. But the family member might say, well, I can't let this happen to him, I have to feed him. And that wasn't what the patient wanted. And so having those conversations while the discussion is still possible to get that sense also allows the person with early dementia to figure out, is this the person who should be making the decision for me? Can they follow through with that? It's not a question of love, it's a question of follow through. Now, since he's historically social, we recommended he attend an adult day health center program. COVID has taken an enormous hit, as I'm sure many of you know, to these programs throughout the state. But these are a mainstay for caregiver offloading and also just making sure that the person has the social interactions and the activities that can help keep them functional and both cognitively engaged and emotionally engaged. And whether it's music or reflective therapy or current events, these are things that patients with dementia really will do well with. We discussed starting him on donepezil, which is also called Aricept, with the hope that it will help with some of his memory and behavior symptoms. And we agreed to revisit the efficacy of this medication on an ongoing basis. And I know we'll talk about that. I know I saw a question about that in the chat box. We also recommended a wander bracelet and making sure that there's an updated photo of Dave to be given to the local police in the event that Dave starts to have any wandering episodes. So now just a summary. As we said, pursuing the diagnosis of dementia is an act of power and love. It enables us to really help determine what this time is going to look like. Sorry, I thought that was a memory test there. I was like, I thought I can remember it, but I guess I can't. So it's the power and to plan and have a say in the future. And for those who love us, for them to actually get some say in how the plan is made and what tools will make them effective caregivers. And it takes multiple forms. It isn't just medicines and milligrams. It is financial, medicinal, logistical, and it's constantly revisited because this is a changing disease through the courses of it. And lastly, just like we're all here together, you can't do this alone. You have to have a team. And so keep building your team.
Wonderful. Thank you so much for that information. I hope everyone will continue to put their questions in the chat box as you think of them for the experts that we have with us tonight. A few came in to me personally. The first question that came in was about medications for Alzheimer's disease, the memory medications. When is it time to stop those medications? My mom is at the middle stage of Alzheimer's, and we are unsure at this point if there is any benefit in continuing the Aricept and Namenda. Her primary care doctor mentioned this. Should we connect with the neurologist? How do you even know if it's even helping? Because she's still progressing.
Yeah, so I can speak a little to this because this is a common scenario in our outpatient clinic. Certainly when patients are progressing and they've been on these medicines for quite a while, it is reasonable to consider a taper. And as with any medication changes in geriatrics, we pick one, we start a taper with a plan for frequent check-ins, and we will prioritize one over the other. So you wouldn't stop both at the same time. And we monitor because everyone can behave differently as they taper off a medicine. So I definitely would encourage people to revisit that and say, hey, we've been on this medicine now for 3 years. we are seeing the dementia progress. What is the benefit of this medicine? These medicines are shown in certain screening, certain research tools to have what's called statistically significant benefit. But in practicality, at a certain level of dementia, they no longer do serve a benefit. And that's why we initiate the taper. But it is very important to taper under the supervision of a doctor.
Okay, great. Thank you. I thought having you both here would be a great opportunity to ask a couple of questions. One, Dr. Russell, for you is, can you talk about why it would be beneficial to see a geriatrician in addition to your primary care? What's the difference between geriatrics and primary care?
It's a great question. So the first thing I'll say is, in geriatrics, our product is time. So our visits are a lot longer than a primary care doctor's visit, just because of the nature of the primary care practice. They are super busy, and our goal is trying to see how this person fits in the mesh of their entire current life, not just the medical problems that bring them in, but what is their their care situation like? What is their home life like? What is their daily life like? It is much more what I would call medicine in motion, or medicine in context. Certainly, if someone were having geriatric syndromes, so of which dementia is one, that's another time where you would want to consider having a geriatrician evaluate you. Other geriatric syndromes include gait instability and falls, urinary incontinence, and frailty. And frailty is, oh yeah, go ahead, sorry, Christine.
If I could just add to that, one of the things that geriatricians are particularly well trained in is understanding how different medications can influence other medications, and also to evaluate with you whether or not a particular medicine's benefit outweighs its burden. There are a number of situations that you may find yourselves in where you have 5 different specialists, and each of the specialists is doing a very, very good job with their particular condition, but may not be thinking holistically about how all the conditions interact with each other. That's really where geriatrics does a lot of its work, is trying to understand how different conditions interact with each other, and thinking holistically about how to weigh the benefits and burdens of both treatment and management for one condition in the context of the other.
Great. How common is it to get an MCI diagnosis? And what does MCI mean? What benefit do you see to catching a cognitive decline at early stages?
Great question. Go ahead, Matt, you start, and then I'll follow up.
It is extremely common. And as I said, it's the start of a path that could be dementia, but it's also a start of something that says investigate for other issues that might be contributing, whether it's nutritional stuff, polypharmacy, medications interacting. You have no idea how many times we come across medicines that are actually dangerous in older adults, that they're taking over the counter, that can look like, wow, what's wrong? Mom is suddenly really demented. And mom is not demented. Mom is having toxic effects of an over-the-counter agent. So it's a pretty common event in geriatric land. I think the other thing you were asking is, does it, sorry, the other part of the question, don't test my memory.
How often
right
does
now.
it progress?
Yeah, so it progresses in a year. It's about, I think, 10 to 15% of
correct.
people progress into dementia range. But again, the idea here is, why is it important to catch it earlier and sooner? A lot of awkward social things happen, like financial exploitation, car accidents, family feuds, and whatnot. These are the things that, if if cognitive impairment is detected, it can either be intervened on, or at least folks can understand what's going on with their family member, because what we're trying to do is preserve this person's self. And if they would not have behaved this way in when they were fully cognitively intact, we certainly wouldn't want them to be exploited in moments like this.
Maybe just a few things to add. When people have so in terms of sort of diagnosis of mild cognitive impairment, if that is a diagnosis that you receive, it's a tremendous opportunity to do a lot of that planning we talked about, and to actually think about any behaviors that you might be able to change that could reduce your likelihood of being one of those 15% that then progress to dementia. So, we recognize that oftentimes people's cognitive changes are occurring long in their brain, long before what we see actually occurs in terms of people's presentation. But we do know that exercise, at least 150 minutes of exercise per week, and diet that includes more of a Mediterranean type diet that also is high in the consumption of berries and nuts and other anti-inflammatory type foods, can be beneficial in terms of helping people keep a healthy brain for longer. So with mild cognitive impairment, I think it just serves as a potential wake-up call. Am I doing all I can to optimize my sleep? Am I actually potentially maybe having just maybe 1, 2, or 3 too many drinks at the end of the day? Perhaps I should be cutting down. These are all opportunities to think about that. The last thing I would say is that there are just a number of really interesting studies now that are ongoing for people with mild cognitive impairment. And so if you are diagnosed with that, it might be of interest to you to actually think about participating in one of those studies. There's a lot to choose from, and you can just decide A, what's of interest to you, and B, whether or not you might be eligible for one of those studies where we'll learn more about whether or not some of these treatments that are right down the pike might add value for you.
Okay. If you met a 95-year-old who was having some problems with her memory, would you consider Aricept?
I would certainly consider Aricept. I don't think any particular age should keep you from receiving Aricept. And I think, to Dr. Russell's point earlier, it's worth monitoring to see if there's benefit or if there seems to be some slowing in the progression of decline. Now, what we will say is that Aricept is not without side effects. It can cause your heart rate to go lower. It can cause some problems with GI distress. And so this is where, again, the benefit burden has to be really evaluated. And I will say from my own professional experience that I do find that as we get older, sometimes our ability to tolerate some of these medicines also declines. So those would be the things to consider. Dr. Russell, you want to add anything?
Yeah, I agree. I think, as we get older, we can have other competing illnesses, especially things like cardiac issues that might make Aricept a little bit of a dicier prospect, but we would just assess it. I mean, the wonderful thing about geriatrics is that it is absolutely individuated. And, there are people who are physically quite robust at 95, and there are people who are quite physically frail at 65. And so we just meet the patient where they're at and make those risks accordingly. I just noticed that there seems to be a theme of questions about seeing a geriatrician, a neurologist, and a primary care doctor. And I figured that I would just probably use this as an opportunity to address that. So oftentimes with primary care doctors, geriatricians will do this thing called co-managing. And what that means is that when patients have geriatric syndromes that need a little bit more time, a little bit more assistance and care coordination, we will work with the patient's primary care doctor to help navigate that and make recommendations both to the patient family and to the primary care doctor. So it's sort of like a consult, but a longitudinal one where we follow the patient through that. you will never go wrong referring your patient to a neurologist or a geriatrician when it comes to dementia questions. What is important to understand is that geriatrics is a medicine-based specialty where we are also very much aware of services in the community, and we work very closely with other sites of care, including home health agencies, community agencies, and whatnot. So we're more involved in the wraparound care that's involved in keeping people functioning in the community. I will partner with a neurologist around my patients with dementia who have complex medical issues. And if I'm thinking, jeepers, do I really want to add this medicine, or this seems to be a kind of dementia that's atypical, one that I'm not as adept at handling alone, I will definitely call on a neurologist. We all have each other's cell phones.
And I think that gets back to the question that was raised about how do you navigate having two doctors, say maybe in two different parts of the country, and navigating the transition between them. This is really important. So where a lot of medicine goes awry is when there's lack of coordination between two very well-meaning physicians. And so I think, one of the things that you can do is be your best advocate self and basically insist on those two doctors talking to each other. It's really important to get a sense of that. And frankly, I think if the two doctors are not communicating, coordinating, they may not be the best two doctors that you want on the team.
Well, along this line with your expertise, the question came about palliative care. When would you recommend getting palliative care involved for someone with dementia?
Another great question. I think because palliative care is really focused on improving quality of life and helping people do as well as they can for as long as they can. And although I didn't say this, or Susan didn't mention this at the beginning, both Dr. Russell and I are board certified palliative care physicians and board certified geriatricians. So we may have a bit of a bias here. We would say that palliative care can be incredibly valuable member of the team to include as part of sort of the journey, especially as someone is starting to have troubles, coming in and out of the hospital multiple times, having troubles with things like swallowing, or having multiple falls that are contributing to their having difficulty coming in and out of the hospital. So I think as we see our loved one declining, especially more precipitously, it's a very good time to involve palliative care. But that being said, I think some of the tenets of palliative care, which is making sure that what's important to you is something that you're thinking about and communicating with others from the get-go, is relevant at the very time of diagnosis. Dr. Russell?
Yeah, I agree with absolutely everything Dr. Ritchie said. I think, certainly issues around feeding and nutrition and serious symptoms, such as what we call like the revolving door hospitalization, when we say, oh, we went in for one thing and now we're back home. We went in for another thing and now we're back to a nursing facility. These are all sort of inflection points when you definitely want to say, stop the liver of the conveyor belt of medicine and say, where are we going? What is important to us? And that is when I will typically say, put my palliative care hat on and work with families around this. No one wants their loved one to be lying in an emergency room hallway, confused and suffering if that hospital experience isn't going to make them better. And so being able to have those honest lines of communication, that's really important. And what we'll often say in palliative care as it transitions to hospice is the question we put to family members is, when are we living with a disease versus dying from it? And it's obviously a very personal answer. But it is something that does give you pause to think, is this something that is really giving me good quality of life, or is this just sort of prolonging my dying and not impacting me in a positive way? So those are the inflection points that I will frequently bring in the palliative principles.
One other quick question about geriatricians. Is there a certain age that you have to be before you can see a geriatrician?
On our website, it says 65, but we've turned away a bunch of 65-year-olds because it really is, there are not enough geriatricians to go around. And most people, if you're playing rounds of golf 3 times a week, and just because you're 65, you don't need a geriatrician. A geriatrician is really someone who can help folks who are dealing with multiple chronic diseases and resultant impact on their, cognition or functional status. Most primary care geriatrics practices, our average age is 84, 83, sorry. It's either 84 or 82. We'll call it in the middle. It's 83.
And this is sort of just along the theme, but I want to make sure this nuance has been addressed. This person says, if you're seeing a neurologist and you have a primary care doctor, at what point would you go to a geriatrician? My mom has mid-stage Alzheimer's, is on multiple medications.
I think it kind of gets to sort of what Dr. Russell was just talking about, which is if it's a simple and straightforward issue that you feel like your primary care, your mom's primary care provider and neurologist are in sync and coordinated and everything is sort of working well, I don't think you need to see a geriatrician. If on the other hand, you feel like things are getting a bit chaotic, out of hand, your mom's function is changing unexplainably, there seems to be a lot going on that just is not adding up, then it may be useful to consult a geriatrician to see if there might be things that might be missed or things that could be added or taken away that actually can improve quality of life.
There's another question here I wanted to get to, came in early. What is the most recent research with neurological impacts of Lyme disease?
Oh, interesting question. So, we live in Lyme territory, so it's a good question to ask. And interestingly, there have been you can't imagine how many studies on this to try to see some kind of relationship between the neurologic sequelae of Lyme disease and the development of dementia, traditional dementia, and there's still no convincing evidence of a relationship. And the development of Lyme neuroborreliosis dementia is incredibly rare. Lyme disease has many neurologic manifestations. It just so happens that it doesn't still happen to be a risk factor for traditional dementia. Dr. Russell, you want to add to that?
Yeah, I think they did a ton of studies on this to see, is there any way of, reversing any cognitive impairment because of Lyme disease post treatment, and there really isn't anything around it. And I have to admit, I don't see a lot of that in our outpatient setting these days.
Okay. Someone has a question about the status of palliative care practice. A couple of years ago, Health Affairs reported projected need to replace some 40% of the current workforce in palliative care practitioners. Is the challenge still that large? And any idea how palliative care teams are bringing savings to hospitals?
So there's a lot in that question. So I would say that one of the things that we both feel deeply passionate about is the need for a more rigorous, strong workforce of geriatricians and palliative care physicians in our community, which is why we're committed to being in an academic medical center to support the next generation of geriatricians and palliative care physicians. Palliative care physicians do have relatively high burnout rates. And that may be what this study is that was being described, where even people who go through the training of palliative care after a time may reduce the amount of palliative care that they provide as a result of burnout. A lot of work that we're doing and others across the country to try to support our clinicians to reduce their risk for burnout. But it is an ongoing challenge, I would say. There have been a number of studies that do suggest, and I would say in large part, this is because our healthcare system is a bit broken, but that palliative care can lead to cost savings in a hospital setting. I think basically what we're seeing there is that it keeps people from getting treatments that are not helpful to them or that they wouldn't want, and that has a byproduct of saving the system resources. Dr. Russell, you want to add anything?
I absolutely agree. I think one thing that's important to understand is that both geriatrics and palliative care are in many ways lost arts in primary internal medicine. And while we are very much our own specialists, it would be very lovely if we could reinfuse mainstream medicine with these skill sets so that everybody is a little P palliative care doctor and a little G geriatric doctor. And that is part of what we're doing here at Mass General in our age-friendly program. So we are an age-friendly health center designated facility now, and Dr. Levine, Sharon Levine is my boss. She's the chief of our section, and she's working with people in the hospital system to make sure that this is an age-friendly place, so that when older adults come into the hospital, whether it's the emergency room or an inpatient stay, or even just a phone call to make an appointment with their doctor, that the principles are there. There are about 7,000 geriatricians in our country right now, of which only half are practicing full-time. And we would need to have about 450 a year extra of what we're graduating to keep up with the population needs. So you can appreciate the fact that geriatricians are saying, I can't do all of this by myself. Something's got to give. And that's why many of us in geriatrics are not only primary care providers, but also sitting in boardrooms, helping people design systems that are, and also help train other clinicians to be, little g geriatrics. Susan, I did get a question about a research study.
Okay.
And it was sort of, how do you choose what, and I'll just ask this of Christine, because I think you might be able to answer this better than I would. How would you choose one research study over another?
Great question. So, I think there's several things. First of all, it's difficult when you just look at what people say about their research studies to even know if you're eligible for them. So what I would do is, let's just use the Massachusetts Alzheimer's Disease Research Center site as an example. They're probably, like I said, 50 plus studies. I'd probably choose 3 and then learn about them and then see whether or not you're eligible. My mother was she was very much bought into the fact that, research would improve her outcomes and quality of life. And, she would just sort of pay attention to what studies she became available that she might be eligible for. And I would say about 1 out of 3 studies she was actually eligible for. She would always be very disappointed when she was not eligible. But sometimes you can't tell just based on what's on the website about a study, or maybe you have to have some additional tests to see if you're eligible, to see whether or not you're eligible. But I think research is one of those really interesting things where we give to the community by participating in research, because it's a contribution that we give to others, and we get something in return as well, because we know that people who participate in research do better. So choosing, I would say, find a few that look like they might fit for you, and then, contact the investigators and see if you might be eligible.
All right, so this is an interesting question. How often should you meet with a doctor? My mother cannot speak on how she's doing. And so what does the doctor do for an evaluation in that situation? And how often is it necessary for the patient to see the doctor?
That's a great question. I think am I muted? No, I'm not muted. Good. In our practice, we tend to see our patients on an average of every 3 months. These are all comers. These are not just patients with dementia. This is just what we like to do because we recognize that our patients are medically complex and things can decompensate. We rarely, if we're dealing with a patient with cognitive impairment, we are not seeing that patient alone. We're seeing that patient in the family unit, whether that's the caregiver, the spouse, or sometimes several family members coming in to give us a report. If the issue, because the patient can't give us the story that we need, we are relying on caregivers to tell us the truth. And I think there was something about guilt and betrayal around someone who's cognitively impaired and speaking to the doctor. I think the important thing, that the way that I will often talk about this with family members, is that this is love. I love my 2-year-old. I'm not going to be asking the 2-year-old to make decisions. I'm going to make those decisions and empower the 2-year-old as much as I can, but really I'm going to make those decisions, and there's no doubt about it. And I think there's an analogy here when you're dealing with a family member who's suffering from cognitive impairment. We're showing love by advocating for them. We're not doing anything untoward. This is really just, how do we keep dad safe? And also recognizing the fact that if the patient has no insight and can't report, the healthcare provider is flying blind. And that's the thing we want to make sure does not happen. So we will do in our practice, if there's no substitute for a physical exam. So we like to see our patients in person, but once we're on sort of a steady path with one another, I tend to alternate. Then thank God for COVID in some ways, because virtual visits are now very much a part of our practice. And so we'll often Zoom in with the patient at, say, the assisted living, where the wellness nurse might be there and a family member might be there, and we just have a meeting that way. And I basically do an office visit remotely. And I get the report from the nurse at the facility, I get a report from the family, and I see the patient.
There was a question that sort of dovetailed on that, with their mothers in assisted living and unable to get to MGH for visits, and wondering if geriatric practice was going to get to the point of community visits. We may speak to the existence of our home-based palliative care as well.
Mm-hmm. Yes, we do have our home-based palliative care program. Dr. Brooke Carlton is leading that. And right now we don't have a bandwidth from our ambulatory geriatric setting. There's only 6 of us, so we wouldn't necessarily be able to head out and do house calls. But I do believe it's a strategic, it is a good strategic plan to do that. And I know that the larger organization is looking into this.
Yeah, and just to add to that, I think there is a growing recognition that for especially people living with dementia, for whom travel to an office visit can be quite taxing, that this needs to be something we think about more in the future. And across the country, there's a growing interest in home-based medical care, and that's certainly something we're certainly advocating for here at MGB as well. I also see that there's a question about neuropalliative care. Maybe I can take that one. So neuropalliative care is a new subspecialty. We're really pleased by the fact that this subspecialty exists. And in fact, associated with it now is a new professional society called the International Neuropalliative Care Society, which I sit on the board for. And it really is trying to bring more of a palliative care lens to all of the neurologic conditions that influence people's quality of life that may be serious and progressive. We at MGH have Dr. Kate Breezy, who is a neuropalliative care clinician. She is both a trained neurologist and received additional fellowship training in palliative care. So we're delighted that we have her as part of our community. A lot of her work is focused on ALS, amyotrophic lateral sclerosis. She does provide some support for dementia care.
So someone made a comment just on possible benefits of research, and I thought it'd be great to just read this out. Other benefits are getting cost-effective testing. Many insurance companies will not pay for certain scans beyond MRIs. And another example may be brain donation preparation.
Thank you for those great comments. That's exactly right. I think one of the things that is just increasingly compelling about research, and especially at a place like MGB and MGH and all of our sister organizations, is that we just have some remarkable clinician scientists here who are really trying to crack the nut on dementia and other neurologic conditions. And just as our chat person said, there are these other additional benefits of actually getting what are still considered, for example, investigational diagnostic testing done that still probably provides profound insight in ways that we wouldn't have available to us in regular clinical practice, because in regular clinical practice, we only have available just what Medicare says they're willing to pay for. So I think there are just a lot of potential benefits, and thank you for bringing those up as well.
Great, and that's all the questions that we have in the chat box. We do have time for a question or two more if somebody wants to put something up really quickly. I just want to thank Dr. Ritchie and Dr. Russell. You've done it was such a great presentation and such a rich conversation of the questions that everybody had. And there's nothing wrong with ending a few minutes early. A lot of thank yous are coming in. Excellent presentation and great questions. Thank you.